and what happens when orgasms can't be achieved or are difficult to achieve. Okay, so what can someone do? How can someone help themselves? What do we in the medical community have to help patients that suffer with orgasm disorder? Fundamental knowledge of sexual function anatomy is critical. They could be missing something really obvious. Orgasm needs to be owned is a legit technique that focuses at teaching an individual to reach orgasm first is the most effective. Oh, hey there. Okay, I guess let's get into another video. And I want to talk about O's, orgasms, and what happens when orgasms can't be achieved or are difficult to achieve. Orgasm disorder is actually considered a legit medical problem. An orgasmic disorder is characterized by bothersome, persistent, or recurrent delay in frequency or absence of orgasm or significant reduction in the intensity of orgasm. Orgasmic disorder affects approximately 20 to 30% of women in the United States. When it comes to men, it's about 10% of men that have bothersome difficulty reaching or absence of orgasms. There's that orgasm gap rearing its ugly head again, which is basically that heterosexual men and heterosexual women have the greatest gap in who gets orgasms and who doesn't get orgasms. I want to stop here for a second and just make sure we understand that orgasm and ejaculation, whether that's male ejaculation or female ejaculation, are not quite the same thing. Orgasm is the peak of sexual pleasure, okay? Ejaculation is the emission of fluids. Oftentimes, orgasms and ejaculation go together, but they don't have to go together. You can have dry orgasms, meaning ejaculation doesn't always have to happen when one orgasms. All right. So what are possible causes of orgasmic disorder? Well, there may be actual physical causes, maybe anatomic abnormalities, like something called phimosis. Phimosis is where the foreskin of a penis is stuck over the head of the penis. By covering the head of the penis, which is packed with nerves, it can diminish arousal, sensation, and the ability to reach climax. The same thing can happen to the clitoris too, y'all. The clitoris can have phimosis too, because it has a hood over it. Yes, clitorises have a hoodie or hood over it. And just like the foreskin, it can potentially get stuck over and covering part of it or all of it. Both the head of the penis and clitoris are densely packed with nerves. So phimosis, again, can decrease sensation and therefore hamper orgasm. Another physical cause is anything that affects blood circulation, peripheral vascular disease, diseases that affect normal circulation of blood. Blood flow to the genitals is an important part of the sexual response and reaching climax. So things like smoking, diabetes, high cholesterol, high blood pressure can all contribute to peripheral vascular disease and can all make it harder to get that O. Nerves are also important. So any disruption in certain nerves can mean that orgasms are disrupted. There are obviously important nerves for allowing us to have the sensation and sensitivity, and then also nerves important for the response to sexual pleasure. And interestingly, sleep is important for orgasm. Sleep disorders are associated with orgasm disorder. Orgasm disorder is almost 2 times higher in women who have sleep apnea. It's over 2 times higher in women who have insomnia. Yes, your sleep is important. I talked in a previous video about how sleep apnea is associated with erectile dysfunction in men. So clearly, sleep health is important for sexual health. Then there are psychosocial causes. These are the mental, emotional, interpersonal, and relationship factors that can make getting that hard to do. Depression. Women and men who have depression are more likely to report issues with orgasm. Women are 2 to 4 times more likely to report orgasm disorder. Relationship conflicts. I mean, if you're not vibing with the person you're sexually relating with, it's going to be hard to reach climax. poor self-image, if the thought of your genitalia gives you disgust or shame, or the thought of sexual activity brings you shame or guilt or anxiety, or you don't like yourself or how your body looks, this all, obviously plays a role and affects the bedroom activity. Cultural factors and religious factors, again, enter in sexual guilt and shame. We know that in religion, there is a lot of sexual repression, shame, and potential guilt, and this can manifest in the bedroom between two healthy adult patients. Then there are a host of medications that can affect the ability to orgasm. Most commonly, antidepressants in the SSRI category. They can interfere with normal communication between your genitalia and your brain, making it harder to reach orgasm. Medical treatments like cancer treatments can also affect orgasms. Survivors of cervical or vaginal cancers are among the highest of reporting orgasmic disorder or problems, and are twice as likely to report difficulty with orgasm and arousal when compared to women in the general population. Recreational alcohol and drugs also can be bad for your sex life. So alcohol interferes with that brain genitalia communication and can make orgasm more difficult. Illicit drugs like heroin are known to make your ability to orgasm harder. And even though short-term cocaine use is associated with heightened sexuality and desire, long-term cocaine use actually makes it harder to achieve orgasms. Okay, so what can someone do? How can someone help themselves? What do we in the medical community have to help patients that suffer with orgasm disorder? Well, number one, if your doctor or provider isn't doing a thorough sweep of your medications, medical history, prior procedures, asking about psychosocial factors, they could be missing something really obvious. So identifying secondary causes like medications and other medical problems or psychosocial factors is critically important. And obviously the idea being to get rid of those factors or lower those factors or treat those factors so that orgasm becomes less difficult to achieve. Beyond this, treatment for orgasmic disorder has really primarily involved sex therapy, which is psychosocial therapy to help address barriers in sexual function, including reaching orgasm. There is actually no FDA-approved medical treatment for any orgasmic disorder. That doesn't mean we can't try certain medical interventions or treatments in an off-label to help patients. But it's important that patients understand that almost anything medically treatment should probably be combined with sex therapy. For my vulva owners who have issues with orgasmic disorder, especially those that have never had an orgasm, fundamental knowledge of sexual function anatomy is critical. Okay, there is a general misconception that women naturally orgasm through their vagina. And y'all, I've said this multiple times, but most of us do not. In fact, only 14% of women can orgasm purely through vaginal penetration. So you are not in the oddball if it takes clitoral stimulation to orgasm. That is the norm, okay? Clitoral stimulation is the norm for female orgasm. So it's important for these individuals to first establish an orgasm alone through masturbation or vibratory toys before they can expect their partner to just know how to do it, okay? Orgasm needs to be owned, all right? Penis owners do this quite well. Vulva owners, we need to be better at this. So I have given masturbation and vibratory toys as homework, okay? And in fact, direct masturbation is a legit technique that focuses at teaching an individual to reach orgasm first through their own self-stimulation and then eventually through partnered sex. We know that manipulation of genitals increases blood flow and sensation. So you get one familiar with their own body, identify areas that are pleasurable to be touched, okay? This is where you explore your own bodies. You can explore different types of sensations or different types of touch, suction, vibration, pressure, or other erotic in the form of videos, audio, or pictures can also be used to enhance. And this should be consistently done for a period of time. One recommended regimen is to do this 2 times per week for at least 6 weeks. Another thing that sex therapists may use is something called sensate focus. And this involves a series of home exercises that you are given with the goal of pleasure, but not necessarily orgasm, okay? So you start first with non-sexual touching. This may mean, okay, I want you to go home and touch parts of your body, but it can't include your genitalia or any erogenous zones, okay? And finding out what feels good to you first with non-sexual touch, and then moving to erogenous zones without sexual penetration and discovering what feels good to you without penetration, and then finally incorporating with penetration at the final stage. And feedback is given along the way to let the partner know what does and does not feel good. Sensate focus is usually partnered, okay? You and your significant other are doing this together. Again, first moving with non-sexual touch and then eventually moving to the final stage of penetration, exploring pleasure and not focusing on orgasm. Along with this, mindfulness training can help. Mindfulness is the mental exercise of focusing on your present moment and present experience without judgment. Y'all, so many of us go through life not in the moment or judging ourselves or our surroundings or whatever while we're doing it. I mean, have you ever been intimate and you're like, man, I hope I don't smell funny, or I wonder if my boobs look weird, or do they like what they're feeling, and just judging all aspects of it, and we are totally missing the moment, okay? Too many of us are also caught up in the destination. We're wondering, are we going to orgasm? Am I going to orgasm? Am I going to get there? Am I going to get there? We're like the kid in the back seat. Am I there yet? Am I there yet? And we're totally missing the beauty of the road trip. We're missing the journey. We're missing out on the actual things that feel good. If you are focused on the end result, you are not necessarily allowing your body to feel all the things that it's feeling in the moment. And so focusing judgment-free on pleasure without mandating that it has to end in orgasm actually can help you achieve orgasm better. Of all of these psychosocial interventions, it appears that directed masturbation is the most effective. Multiple small randomized trials have found that directed masturbation yields the best results. There was a randomized trial comparing 12-session directed masturbation to 12-session psychotherapy and sensate focus in 32 patients with primary female orgasmic disorder. These were women who had never had an orgasm, and found that 90% of the directed masturbation group was able to experience orgasm. That's wonderful. This is compared to 53% in the sensate focus psychotherapy group. So sensate focus and other psychotherapy interventions are effective. It appears that directed masturbation as part of that is the most effective psychotherapy intervention. What's more common is something called secondary anorgasmia or orgasmic disorder, where patients will have had orgasms in the past, but they can't anymore, or they're significantly harder to get, or they're significantly less intense. And secondary orgasmic disorder can be approached the same way as primary. Directed masturbation, sensate focus, mindfulness, all good practical things that anyone can incorporate to improve their sex life and to enjoy better O's. Secondary orgasmic disorder is most common in older women, especially perimenopause and beyond. This is where hormones play a bigger role. We know that estrogen deficiency leads to changes the actual anatomy of the vulva. It can mean that the clitoris is smaller in size. It can mean that the clitoris is stuck under the hood. It can decrease labia minora, and it can lead to decrease in blood flow through the genitals, okay? And so addressing potential anatomic changes as a result of age and hormones can be really important in helping patients get orgasms again. For instance, if a clitoris is covered by the hood and stuck, we have a treatment for that where we can release the adhesions from the hood to the clitoris. Testosterone is another important hormone for sexual function in women and men. okay? Not just for men, but in vulva owners too. And that declines gradually with age. So hormonal treatments, either locally on the genitalias, often in the form of creams, or systemically as hormone replacement therapy, may help improve orgasms. Topical Viagra. Yes, Viagra can be formulated into a topical cream, has been used with admittedly mixed results, but very, very little risk. I mean, it's extremely safe to try this. And so most patients who are presented with the option of using topical Viagra will find it worth trying to see if it helps boost their orgasms. Viagra, for those who are wondering and scratching their head, like, how the hell is that going to work? It is a vasodilator, meaning it dilates blood vessels and it increases blood flow. I mean, that's how it helps get erections. It increases blood flow through the erectile tissue in a man's penis. But clitorises have erectile tissue too. And so medications like Viagra can potentially increase blood flow into the clitoris, heightening sensitivity and making orgasm more intense or easier to get. There's something called the O shot, which is platelet-rich plasma. It's using your own blood, spinning it down to the part that's rich in platelets, and then giving that back to you in the form of an injection, typically in the clitoris and the upper anterior wall of the vagina, i.e. G spot. And that may, in some individuals, improve their ability to achieve orgasm. It's important to note that these medical interventions, which are largely very low risk, have yet to have robust medical data behind them. And so we're ever evolving in what we in medicine can do to help people have orgasms or achieve better orgasms. I think it's our responsibility as medical professionals to make sure patients understand realistic expectations, to understand the importance of potentially incorporating psychosocial therapy, to understand the importance of body exploration and self-stimulation, and to do this all in a judgment-free environment, okay, when treating patients who have orgasmic dysfunction. So there you have it. Cheers to more orgasms in your future. Let me know what you think. Comment below. I'd love to hear from you all. And obviously, make sure you subscribe and tell a friend so that you can join me every week for all things down there right here.